So very good afternoon. I'm Dr. Komal, and I'm going to present my study over the integrated eyelid myomectomy to treat the patients with blepharospasm and apraxia of lid opening. So as we all know, apraxia of lid opening is a non-paralytic inability which affects the quality of life, and the available treatment options are ineffective and have a high risk of complications. So the debate is always in between which alternative treatment is important. So most of the researcher has researched over the protractors of the eyelid, and many of the studier has also accepted results with the upper lid myomectomy. However, 50% of the patients eventually require lower lid myomectomy. So considering this, the aim of the study was to assess the effectiveness of upper and lower lid myomectomy in relieving the blepharospasm. Primary objective was to assess the improvement in blepharospasm using the functional disability score, assess the dry eye photophobia, and the secondary objective was to see the impact of the treatment on patient functioning using the disability questionnaire. So these were the study parameters. We included the patients who were refractory to botulinum toxin with no prior eyelid surgery, and we excluded the patients with other tonic disorders and patients with other eyelid abnormalities. Talking about the surgical technique, so we concentrated over the protractor of the eyelid, including the orbicularis oculi, the corrugator supercilia, the depressor supercilia, and the procerus, and its described extent. Coming to the surgical video. So we usually tried the blepharoplasty incision followed by excision of the orbicularis oculi, where the plane of dissection was just below the skin, where we concentrated more over the protractor like the procerus and the depressor corrugator. Here, while doing so, the important structure like superior ophthalmic vein has to be identified and saved. So the similar procedure was done in the lower eyelid as well. So altogether 24 eyelids or 12 patients were included, where all underwent upper and lower lid myomectomy. Additional few patients, we did an additional procedure of levator aponeurosis resection along with the canthal plication as well. So these were the postoperative results. At the end of 1 month, almost 17% patient responded that their ALO symptoms was relieved, with 33% improvement in the dry eye symptoms, where at the end of 1 year, almost all patients were relieved of ALO and 83% had improved dry eye symptoms. Only 2 patients required botulinum toxin injection at the end of 1 year, and mainly to the lower eyelid, however with the minimal doses. We also found statistically important results at the end of 6 months and at the end of 1 year. There was also improvement in the photophobia and dry eye at the end of 1 month and 6 months. Along with the minor and manageable complications, the marked forehead numbness was the important one, so all the patients should be counseled before the surgery. Coming to the discussion part, so the injection botulinum toxin was effective in relieving the blepharospasm, but not successful in treating the dry eye symptoms. So when we talk about myomectomy versus dry eye versus blepharospasm, we found that a very high incidence of dry eye in our study. Nevertheless, almost 80% of the patients experience improvement in the dry eye after the surgery. And the most probable reason to that could be the reduced protractor contraction that acts over the canaliculi and induces a decreased pump function during blinking, and hence increase the tear retention, or maybe the result of correction of the eyelid malpositions. But being a pilot study with the limited cases, we need to find out the exact outcomes and explanation in the terms of dry eye. Talking about the surgical aspects, we advise to leave a small amount of marginal pre-tarsal orbicularis in order to avoid any ectropion or tearing after the surgery. So one may ask, what is the major or the maximum limit till the orbicularis can be removed? So the fact is that it is virtually impossible to remove all the orbicularis, and the surgeon have to allow several hours to expurgate all the accessible protractors, and the results are directly related to the completeness with which the orbicularis is removed. So to conclude, integrated eyelid myomectomy has been shown to be a viable treatment options in the refractory cases of blepharospasm with ALO, with an added advantage of comparatively definitive, cost-effective and bilateral procedure. We do not believe that this or any other procedure cures the ALO associated with blepharospasm. Since ALO with associated blepharospasm is a functional condition, surgery is indicated at the rehabilitating the patient and allowing them to live a better quality of life. Thank you.
You mentioned certain more additional procedures apart from mammectomy. Would you please show that slide? How does it affect the final outcome? Is there any subgroup analysis?
Yes, ma'am. So there are three patients where we have done LPS reinsertion because there was LPS aponeurosis, disinsertion, and canthal plication also was done. So it might affect the result of the study.
Did you analyze it in the groups
No,
where you did the additional procedure? Is there
no,
how
it
it's
was
going
a
to
pilot
affect?
study, so we're not that done in this. But yeah, could be.
Yeah, great study, Komal. So you showed in the outcome part that at 1 month, only 16% the symptom was reduced. However, over a period of 1 year, it was 100% of the patients who said that they were free of their symptoms. So what is the most possible cause for the same?
So as I already said, we targeted most of the protractors, like including the orbicularis and the procerus and all. That could be the reason. But yeah, the delayed positive results, that we have to study more.
Yeah.